cell disease, resulting in constant RBC destruction by the spleen. طبعا هاي الRBC لأن abnormal من تمر بالسبلين، السبلين ما راح تميزها لأن متعودة على النورمال RBC. ايش راح يصير؟ يصير destruction of this sickle-shaped RBC, and this may lead to functional acyclemia, which is susceptible to infection. Sometimes those sickle cell diseases, when those cells pass through the artery, they may aggregate and lead to infarcts. So جلطة. It will cause arterial occlusion, leads to infarcts. والinfarction طبعا من ينسد الشريان ايش راح يصير؟ يصير pain. We call it pain crisis. The pain may be in the lung, acute chest syndrome, or maybe in the brain, stroke, or maybe in the heart. We call it myocardial infarction. So what we should do حتى نمنع هاي الاجريجيشن، لازم هاي حالة مستعجلة وننطي المريض، نبدي بالفلويد، keep the patient hydrated حتى يخفف الدم وتقل هاي الانسدادات. You should treat pain with morphine or pethidine, and we should take infection seriously with antibiotics. We have some types which are different. We call it sickle cell C or sickle beta thalassemia. ده مريض عنده sickle cell disease، يتزوج مريضة عندها ثلاسيميا، راح القسم من الأطفال يطلع عندهم sickle cell B thalassemia. مثل ما قلنا sickle cell anemia, this is due to defective hemoglobin formation. And this will lead to certain signs and symptoms of the patient, and the patient may suffer from weakness and fatigue, تعب, shortness of breath لأن كمية الدم اللي تروح للرئة قليلة ويحتاج الجسم إلى كمية أكثر من الأكسجين, and this will lead to shortness of breath. Pain in joints sometimes, limbs, abdomen, هاي نسميها crisis. يصير acute bone crisis or acute abdominal crisis. Nausea and vomiting because it will involve the gastrointestinal tract. Sometimes there may be systolic murmur and cardiomegaly. The oral manifestations of sickle cell anemia, you may find pallor, شحوب, generalized osteoporosis, سوفان العظام, loss of trabeculation of jaw bones, من تباوعون بالعظام الفك، إذا تأخذون مقطع منها تشوفون هاي التشعبات الموجودة داخل العظم قليلة, loss of trabeculation. And this will lead to delayed eruption of teeth. بالأطفال eruption of teeth الأسنان تتأخر, and it will lead to enamel hypoplasia. Dental management of patient with sickle cell anemia. At first, you should confirm the patient physician the condition is stable. This is physician, and you should take agreement of the physician to do extraction of the teeth or to do operation for him. دائما تنطوا arrange short appointment, موعد قصير, and avoid long and complicated procedures. Institute aggressive preventive dental care, and you should avoid oral infection, and you should treat aggressively. معناها تنطي الانتيبيوتيك بسرعة، تنطي 2 or more in order to get rid from infection. When you use local anesthesia, you should use it without epinephrine. ما تخلي epinephrine أو adrenaline for routine dental care. For surgical procedure, you should use epinephrine in small amount, small dilution, 1 to 100,000 in local anesthesia. Use prophylactic antibodies for major surgical procedure, and avoid liberal use of salicylate، لأن salicylate يساعد على النزف، والمريض احتمال ينزف، معناه احتمال أكثر النزف يصير. So you should not use salicylate. And if you want to use analgesic with pain control, you can control it with acetaminophen. Acetaminophen. Patient with sickle cell anemia should only receive dental treatment when they are not in crisis. معناها المريض ما يصير عنده مثلا acute crisis of bone، مثلا bone pain، أو عنده infarction، أو عنده جلطة بالدماغ وتعالجوه. البيشنت لازم stable, and you should take the agreement of his physician. Management of caries is extremely important. An untreated caries leading to periapical infection can precipitate a crisis. So you should manage carefully. Infections has to be managed aggressively with local and systemic measures, including appropriate dental treatment, antibiotics, and surgical procedure if necessary. That means incision and drainage or extraction. The presence of angular cheilitis. احنا انطيناكم الدرس اللي فات قلنا الانجولار هاي الكيليايتس بالانجل اوف ذا ماوث. هنا التشققات الموجودة بالانجل اوف ذا ماوث could be due to iron deficiency anemia. But the presence of angular cheilitis in the patient with iron deficiency anemia suggests the possibility of candidiasis, which can be effectively managed with the antifungal medication previously described. أساعدكم هذا السلايد. هنا تشوفون ال RBCs, and in one of those RBCs there are blue dots نسميها البيزوفيليك ستيبلينج. هاي البيزوفيليك ستيبلينج it could be due to lead poisoning، تسمم بالرصاص lead poisoning, but it could be due megaloblastic anemia, sickle cell anemia, and sideroblastic anemia, which is common in elderly people. شنو sideroblastic anemia؟ The sideroblastic anemia, this is due to failure of synthesis of porphyrin ring. This is a hereditary disease, but it could be acquired due to use of INH, which is used in tuberculosis, B6 deficiency, and lead. Sideroblasts may be present in the blood smear. If you look to this slide, with refractory anemia, you can find ring sideroblast, a blue stained hemosiderin deposit in the mitochondria of erythroid precursors from apparent ring around the nucleus. شوفوا around the nucleus هاي الأسهم الخضراء تأشر عليها. This is a sideroblast. Macrocytic anemia. قلنا we have 3 types of anemia. المicrocytic اللي الفوليوم less than 80. الnormocytic from 80 to 100 and macrocytic more than 100. معناها حجمها يصير أكبر شيء نسميها macrocytic anemia, and there are many causes of this anemia. One of them drug induced, like hydroxyurea, AZT, MTX, chemotherapy, and anticonvulsant, which is used in epilepsy. B12 and folate deficiency also cause macrocytosis. Myelodysplastic syndrome, this is due to infiltration of malignant cell or any other type of infiltration, and cause also macrocytic anemia. Liver disease, alcohol abuse, both of them cause macrocytic anemia. Reticulocytes, احنا قلنا الابنورمال RBC or early RBC present in the blood in percentage of 1%. If it is more than 1%, this is abnormal. And when it is present in the blood, should be present with nucleation. We call it reticulocyte. And the cell, of course, is large in size, and so it is one of the causes of macrocytic anemia. Hypothyroidism, this is deficiency of thyroid hormone. وهذول المرضى اللي عندهم نقص بالثايرويد هرمون هم يصير عندهم السيلز macrocytic, and they may develop macrocytic anemia. Folate and B12 deficiency. Serum folate usually sufficient, but if folate level is normal. But folate deficiency is suspected, and you should check serum homocysteine, which is elevated because of impaired folate-dependent conversion of homocysteine to methionine or RBC folate. And this will lead to macrocytosis also. B12 can be spuriously low, a more sensitive and specific test is serum methylmalonic acid level will be increased if B12 is low. You know B12 is absorbed in the terminal ileum of the people, and any resection in that region, it may cause B12 deficiency. In cases with pernicious anemia, there is deficiency also of B12, and can be confirmed in the diagnosis by doing Schilling test for B12 deficiency, or to detect parietal cell antibody or intrinsic factor antibody. Those slides are present in cases with B12 and folate deficiency. The first slide to the left, you can see large RBCs. The size is large, and you can see abnormal white blood cell, which is hypersegmented, and it contains many nuclear lobes. These are present in cases with B12 deficiency. Myelodysplastic syndrome, this is a primary bone marrow disorder often found in elderly. And if you look to this slide, you can see there is macrocytosis, and there is abnormal white blood cell, which contains two lobes and a ring between them. This is called pseudo-Pelger hue abnormality, which is present in cases with myelodysplastic syndrome. وإحنا قلنا myelodysplastic syndrome, this may present because of infiltration of malignant cell, or could be due to fibrosis of the bone marrow. هسه نجي على النورموسيتيك انيميا. النورموسيتيك انيميا احنا قسمنا الانيميا الى مايكروسيتيك، نورموسيتيك and ماكروسيتيك. نورموسيتيك انيميا هي when the size is from 80 to 100. هاي نورموسيتيك. إذا أكثر more than 100 هاي ماكروسيتيك انيميا. إذا أقل من 100 مثلا 80 not more than 80 هاي microcytic anemia. Normocytic anemia, this is large and complicated group of disorder. There are a lot of causes like hemolytic anemias, anemia of chronic disease, bone marrow disorder, and the nutritional early iron B12 folate deficiency and renal insufficiency. Nutritional anemia, this is due to iron deficiency, which cause microcytic anemia, but sometimes it may cause in the early stage macrocytic anemia, and B12 folate deficiency, which can cause macrocytic anemia. Can present with normocytic anemia also, especially if both deficiencies are concurrent. And in such condition, you should check the iron studies. Doing serum iron with the ferritin and iron binding capacity. And B12, you should do Schilling test, while folate, you should check the serum folate. Anemia of renal insufficiency. Anemia of renal insufficiency. This is with unremarkable peripheral blood smear. And you know that kidney diseases cause deficiency of erythropoietin, which is secreted by the kidney. And by this enzyme, the bone marrow will be stimulated to produce RBCs. Anemia usually severe and symptomatic, sometimes mild to moderate. And if you do iron study, it will be low in such conditions. But the cause is due to mostly due to erythropoietin deficiency. عندنا الهيموليتيك anemia. This is anemia due to hemolysis. عندنا two main types: extravascular destruction of red blood cells, وعندنا intravascular destruction of red blood cells. Extravascular destruction, two types: intrinsic red blood cell defects like enzyme deficiencies, مثل glucose 6-phosphatase dehydrogenase deficiency. هذا يؤدي also إلى anemia وhemolysis. أو hemoglobinopathies like sickle cell disease, thalassemia, and unstable hemoglobin, أو membrane defect as in hereditary spherocytosis and elliptocytosis. Extrinsic red blood cell defect may be present in cases with liver disease, hypersplenism, infection like Bartonella, malaria. These are rare. Oxidant agent, example, dapsone, which is used in treatment of leprosy. Other agent, example, lead, snake, and spider bites. Microangiopathies, example, due to disseminated intravascular coagulation and the thrombocytopenic purpura, or due to autoimmune hemolytic anemia due to warm or cold antibodies, intravenous immunoglobulin infusion, and large granular lymphocyte leukemia. To mark, there is no need to know all those details، بس لازم نعطيكم إياها حتى تعرفون التقسيمات مالتها. إن النوع الثاني intravascular destruction of red blood cells. This is due to microangiopathy, مثلا when the blood passes through the aortic stenosis or prostatic valve leak. This will lead to hemolysis of the RBCs. أو due to transfusion reaction، مثلا ABO incompatibility، مثلا مريض هو مثلا جروب B وينطوا المريض عنده جروب A يصير hemolysis. Infections مثل الكلوستريديال infections، severe malaria يسوي hemolysis. Paroxysmal cold hemoglobinuria and paroxysmal nocturnal hemoglobinuria. These are conditions in which there is hemolysis because of coldness, or sometimes present at night in certain people, and it may run in families. Following intravenous infusion، مثلا نعطي RH positive أو RH negative. مثلا RH positive نعطي RH negative يؤدي إلى hemolysis also. Following intravenous infusion with hypotonic solution and the snake bites، عضات الحياة تسوي تؤدي إلى hemolysis. هسه إذا عندك مريض عنده hemolysis شو تسوي له؟ أول شيء تدزه LDH enzyme which is increased in such cases. تقدر تدز indirect bilirubin which is also increased. Haptoglobin decreases. Reticulocyte count, of course, it is increased in hemolytic anemia. And urine hemosiderin test also is useful. And you can do COMS test. This COMS test will differentiate the cases if they have antigen-antibody reaction or not. It is positive in cases with antigen-antibody reaction, while it is negative in other cases. Other cases with hemolytic anemia due to intrinsic causes. عندنا السفيروسايتوزس والسيكل سيل ديزيز شرحناهم. عندنا السفيروسايتوزس this is not so common, and هاي بعكس الشكل مع الايرون ديفيشنسي. بالايرون ديفيشنسي قلنا اكو فراغ يصير pillar in the center of the RBC. هنا بالعكس يصير السيل compact and it is dense. هاي بالجل على اليسار الاسهم السود أشر عليه تشوفون السيلز. Although it is small, but it is dense and there is no pillar in the center. هاي يسموها spherocyte. بينما على الجهة اليمنى this is a sickle cell disease. تشوفون الأسهم السود، الأسهم الزرقاء، اللون الأزرق تأشر على سيلز شكلها مثل الخنجر نسميها سيكل سيل، وهاي الثانية اللي تأشر باللون الأحمر نسميها تارجت سيل. توجد أكو condensed area in the center of that cell. This is a common picture of sickle cell disease. عندنا بالأوتو هيموليتيك أنيميا يصير ماكروسايتوسيس أهم شيء and nucleated RBC اللي تأشر عليها باللون الأزرق. بينما بالمايكرو انجيوباثيك أنيميا نشوف أكو fragmentation، هاي الأسهم السود to the right تأشر عليها fragmentation of the RBCs. هاي يصير بالمايكرو انجيوباثيك أنيميا. الأنيميا of chronic disease thought to be a cytokine-mediated process which inhibits red blood cell production or interferes with action of erythropoietin. Therefore, disease needs to be inflammatory. And in such condition, such conditions may be present in chronic diseases. مثلا المريض عنده rheumatoid arthritis أو عنده tuberculosis or any other chronic disease. And it is due ما عندهم iron deficiency, but they cannot use iron, so there is decreased iron utilization and mobilization. And this is seen with rheumatic disease, chronic infection, and malignancy. بالexamination indices المؤشرات اللي تأشر عليها تشوفون الايرون قليل low iron and low iron binding capacity. الفيرتين also abnormal and may be seen in conjunction with iron deficiency. Anemia due to primary bone marrow disease. عندنا المايلوديسبلاسيك syndrome اللي هي due to infiltration of malignant cells or fibrosis. The bone marrow infiltration will show nucleated red blood cells found in circulation, and there may be formation of prolo as in cases of multiple myeloma. This is a malignant disease also of the blood, and you can see هاي السود تأشر على تجمع ال RBCs المتسلسل نسميه رولو ROULEAUX. The white blood cell may be abnormal also, and the diagnosis should be confirmed in this condition. Myelodysplastic syndrome should be confirmed by doing bone marrow biopsy. You cannot diagnose it from blood film. So to diagnose a case with anemia, you should do complete blood thorough evaluation of the patient and physical examination and medical history. So you should take a complete history from the patient. Examination should be full with doing all the blood tests which the patient needed. Laboratory test for anemia, you should send the patient for complete blood picture, blood film, white blood cell count, differential count, platelet count, hemoglobin estimation. Stool hemoglobin test is important, local test to exclude bleeding in the gastrointestinal tract. Peripheral blood smear, blood film, doing blood film to look for the abnormalities in the RBCs. Iron level, if it is high or normal or low. Transferrin level also should be done. Estimation of ferritin, which will give you an indication of iron storage inside the body. Folate should be examined, and vitamin B12 by doing Schilling test. Bilirubin should be done to exclude hemolysis, lead level to exclude anemia due to lead poisoning. Hemoglobin electrophoresis, this is important in the diagnosis of thalassemia. Reticulocyte count, if it is increased, this is one of the indications to the diagnosis of hemolytic anemia. Lung function test to exclude any abnormality in the lung. Right renal function test to exclude kidney disease. And bone marrow biopsy is the last one to diagnose blood diseases. Anemia treatment, always if you have a patient with hemoglobin less than 5 grams per deciliter, you should not hesitate in giving a blood transfusion after doing cross-match. Iron supplementation is important in diagnosis of iron deficiency anemia, erythropoietin analog in cases with renal failure, and B12 and folate in cases with deficiency of B12 or folate. If you look to the smear, you can see the abnormal RBCs, which is called helmet cell, and teardrop cell to the right side تشبه الدمع، شكل الدمع. هاي موجودة تصير في الكيسات with fibrosis, bone marrow fibrosis، تليف نخاع العظم. Accidental management of anemic patient. There are several management considerations in the dental management of patient with hematologic disease, and patient with anemia is or was associated with stomach ulceration. You should correct, you should treat the source of bleeding as a source of the gastrointestinal bleed. Aspirin or non-steroidal medication should be avoided. The drugs combined with phenycetine should not be prescribed for patients with anemia caused by glucose 6-phosphatase dehydrogenase deficiency. This form of anemia has also been associated with increased incidence of sensitivity to sulfonamide, aspirin, and chloramphenicol. Now we are coming to the end of this lecture, and thank you for your presence. And if you have any question, please, you can ask. We have 7 minutes. you can ask about أنوار جبار كاظم.
نعم دكتور.
عندك سؤال؟ ما
لا
عندك؟
دكتور مشكور.
عجب. سارة حازم. سارة
نعم.
حازم، شلون تميزين between iron deficiency anemia؟ ها؟ شلون؟ ما تسمعين الصوت؟ شلون تميزين between iron deficiency anemia and B12 deficiency بالبلد فن؟ جاوبيني. منو يعرف الجواب؟ شلون تميز بين نقص الحديد ونقص B12 إذا تسوي له بلد فن؟ أحد يعرف؟ موسع حكينا. فرح إحسان مهدي جاوب. تعرفين؟ أو نور تحسين هويدي. هدير عباس علوان. ليش تسدون الميكروفون؟ أحلام عادل. أحلام عادل جاوبينا. تميزون بسهولة تسوي بلاد فن إذا الار بي سي صغيرة مايكروسيتك معناها due to iron deficiency، وإذا large may be due to B12 deficiency. محمد مصطفى علي، شنو الكوزز اوف مايكروسيتك انيميا؟ عدد لي الكوزز اوف مايكروسيتك انيميا، او انطيني مثلين 2 examples of microcytic anemia. يلا جاوب.
ما اعرف.
ها؟ شلون؟
ما اعرف دكتور.
عجب ما تعرف. وهاي هيثاء سعد ما تعرف؟ انتين ما تعرفين؟ سارة عمار مهدي، يلا جاوب. Two causes of microcytic anemia ان الايرون deficiency anemia والثلاسيميا. الايرون deficiency anemia due to deficiency of iron، بينما الثلاسيميا this is a hereditary disease due to abnormal hemoglobin. الزهراء وئام تحسين، جاوبين على هذا السؤال. شلون الميجالوبلاستيك انيميا شو تشوفين بيها بالبلد فن؟ ميجالوبلاستيك انيميا، او شنو الكوز مع الميجالوبلاستيك انيميا؟ ما تعرفين؟ جاوبوا لو اي لو لا. انت عمار ياسر، امير موفق، زهراء صادق، فاطمة مسلم، كلكم ما تعرفون؟ زين اذا انتم ما تعرفون ليش ما تسألون؟ منو عنده السؤال هسه؟ Megaloblastic anemia, this is due to deficiency of vitamin B12. And you should do, to confirm the diagnosis, you should do a Schilling test. And by blood film, you may find macrocytic RBC with هايبر سيجمنتد وايت بلاد سيل. انت ضفاف جاوبي. عندك سؤال؟ طيبة، علي مكي، أبد ما عندكم أسئلة؟ Now we will come to the end of our lecture, and next time please you should read. أنا أدزلكم المحاضرة قبل لا أنطيها بيوم، المفروض تقروها وتحضرون الأسئلة مالتكم، أو من بعدين ثاني يوم من أجي أحكيها أسألكم مثلا تناقشوني بها، إذا عندكم أسئلة تسألون. يعني شلون تفتهمون المحاضرة؟ هسه إن شاء الله مرة الثانية تحضرون المحاضرة قبل بيوم أدزها، تحضروها وتجوني تناقشوني بها.
ان شاء الله دكتور.
ان
شاء الله دكتور.
ان شاء الله. شكرا على حضوركم.